Yes, we are live. Okay, hi everyone, good evening. And as I had promised you, I'm here with you today to discuss with you all the basic MCQs which are related to bleeding in pregnancy. That could be abortion, that could be ectopic, that could be molar pregnancy, antepartum hemorrhage, or PPH, right? So now we are going to go quickly. I'm going to go a little fast because I know all of you have shortage of time. And I hope all of you were able to revise and follow the schedule which I have given you, right? So coming to the first question, and first question is match the description with the type of abortion. Now that's very, very important. You know, the various types of abortions, they have been asked in different format. They will give you a clinical situation and they are going to ask you that what is that particular type of abortion which has been described in the question, so that we can come up with, we have all the abortions together, right? I can revise quickly with you the different types of abortions together. So I have given you this question and now you're going to tell me what each description is telling you, right? So, number one is uterine bleeding at 12 weeks gestation accompanied by cervical dilatation without passage of tissue. So, over here in first statement, what is the first statement saying? That there is cervical dilatation without passage of tissue. So, tell me, cervical dilatation without passage of tissue, what does that mean? Which kind of abortion? Without passage of tissue, that is something which you have to keep in mind. So if the cervix is dilated and there is no passage of tissue, that means they are talking about, excellent Adi, it is inevitable abortion. So please remember that in the questions, if they say that product of conception has not come out, right? Product of conception has not come out, and they say that the os is open, that is cervical internal os is open, then it means they are talking about inevitable abortion, right? And if they say that product of conception has not come out but os is closed. Now, if os is closed and product of conception has not come out, that means either it can be a case of threatened abortion or it could be a case of missed abortion. Right? And how are you going to differentiate between them? Threatened abortion and missed abortion. Threatened abortion and missed abortion can be differentiated based on the height of the uterus. In threatened abortion, height of the uterus will be equal to the period of gestation. Whereas in missed abortion, height of the uterus will be less than the period of gestation. Now, if your question says that product of conception were seen coming out, right? So the product of conception was seen to be coming out. Now in this case, if the product of conception is coming out, right, now what you have to see, it could be a case of incomplete abortion. In incomplete abortion, the os will be open, or it could be a case of complete abortion, and in complete abortion, os will be closed, right? So the entire product would have come out and the os would be closed. Clear? So first over here, it is cervical dilatation without passage of tissue. That means they are talking about inevitable abortion. Second, uterine bleeding at 7 weeks without any cervical dilatation. Bleeding without dilatation, no passage of conception. So they are not telling you that product of conception has come out. So no product of conception has not come out, right? And there is bleeding without dilatation. That means os is closed, right? So this over here is a case of threatened abortion. Clear to all of you? Yes. So number 2 is 3. Then coming to the third one. Third is passage of some but not all placental tissue. Some placental tissue has come out, some product of conception has come out, but not the entire tissue. So now tell me, what is this? Some has come out, but not the entire. So if some product of conception comes out, but not the entire, that means it's a case of incomplete abortion. Clear to all of you? Yes? Good. Next question, then fourth statement. Fetal death at 15 weeks of gestation without expulsion of any fetal part or maternal tissue for 4 weeks. So the fetus is dead, but nothing has come out and the mother is not aware that the fetus is dead. What is that? That is missed abortion, right? So that is what is missed abortion. In missed abortion, no product of conception will come out, right? And mother will not even be aware that the fetus is dead inside her. Then expulsion of all placental tissue from uterine cavity. So if entire thing has been expelled out, what is that? If entire product of conception comes out, that is a case of complete abortion. I hope you've understood this. Right? So if entire product of conception comes out, that is complete abortion. Incomplete is when half of the product, some part of the fetal tissue is out, rest is inside, that is incomplete abortion. So there are only two kinds of abortions in which you are going to get history of product of conception coming out. One of them is incomplete, in which some part will come out, rest will be inside, and internal os will be open. If it is a case of complete abortion, entire product of conception will come out and the internal os will then become closed. Very good. Now, a similar kind of question is this question, which I want you to see here first. See this question. Now, in this question, I want you to read the question very carefully. A 29-year-old female complains of heavy bleeding at 10 weeks of pregnancy. So, she's having heavy bleeding at 10 weeks of pregnancy, right? Her vitals are BP is 80/50 and pulse is 110 per minute. Her abdomen is soft, non-tender and non-distended. Examination shows blood in vagina. Os is open and a 10-week size uterus is seen, which is non-tender. The next step in management is, now tell me. Now tell me. What is this? What is your diagnosis over here? Quickly tell me your diagnosis in this case. So in this case, patient is coming to you with heavy bleeding, right? Now, please understand that whenever a patient comes to you with bleeding in early pregnancy, either it could be abortion or it could be ectopic or it could be a molar pregnancy, right? Now, in case of abortions, there is more bleeding and less pain. Whereas in case of ectopic, there is more pain and less bleeding. So, the most consistent symptom of ectopic pregnancy is pain. Right? Number one. So in this case, patient is coming to you with heavy bleeding. Number one. So heavy bleeding, the moment they say, I think a little bit more towards abortion rather than ectopic. That is one thing. Number two. Now her vitals are 80/50 and pulse is 110 per minute, which means patient is in shock. Her vitals are unstable. But then if it is a case of unruptured ectopic, which would be if her vitals are unstable, I am thinking more of unruptured ectopic. It is more of ruptured ectopic, sorry. So when the vitals are unstable, I am thinking more in favor of ruptured ectopic. Now in case of ruptured ectopic, is the abdomen going to be soft, non-tender and non-distended? No. There will be hemoperitoneum. So you are not going to get a soft, non-tender, non-distended abdomen. Right? So this is one thing which is going against ruptured ectopic. Now go further. Further, the question is telling you that there is blood in vagina, os is open and a 10-week pregnant uterus size, 10 weeks pregnancy, 10 weeks uterus size you are getting. So if uterus is enlarged, can this be a case of ruptured ectopic? No. Right? So this is not a case of ruptured ectopic. So all those who are saying that I'm going to do laparotomy or laparoscopy or cullocentesis, that is wrong. If it is a case of ruptured ectopic, then only you are going to go for laparotomy, right? You are not, this is not ruptured ectopic. What is this? This is simply a case of abortion. And which kind of abortion? Now over here you are getting that patient is having bleeding. They have not said anything about product of conception coming out. Number one. Number two, the height of the uterus is corresponding to the period of gestation and os is open. So if os is open, there is no history of product of conception coming out and height of the uterus is equal to the period of gestation. That means it's a case of inevitable abortion. Why are you saying Dr. Narendra threatened abortion, Radhe threatened abortion? In threatened abortion, os will not be open. In threatened abortion, os will be closed. In threatened abortion, os is closed. In inevitable abortion, os is open. So बच्चों please pay very attention. अगर आपके question में दिया है कि bleeding हो रही है, there is bleeding and os open है, right? Product of conception बाहर नहीं आया है, it is inevitable abortion. If in your questions it is given that os is closed, bleeding हो रही है and height of uterus is equal to the period of gestation, os is closed, then that is a case of threatened abortion. Now, okay, why not incomplete abortion? Incomplete abortion mein, there are two things which are going against incomplete abortion. Number one, they haven't told you that product of conception has come out, right? Number two, incomplete abortion mein, height of the uterus is less than the period of gestation because common sense hai, incomplete abortion mein product of conception bahar aa jata hai. Right? Some part comes out. Obviously, if some part of the fetus is coming out, so height of the uterus will be less than the period of gestation. Right? So this is what you get in incomplete abortion. Height of the uterus less than the period of gestation. That is why I am saying it is a case of inevitable abortion and not a case of incomplete abortion. Now just tell me. Yes. So over here, you are right that inevitable abortion में shock के chances कम होंगे. Shock you see more in case of incomplete abortion. Right? But यहाँ पे जो question frame किया गया है, it is done in such a manner that it is a case of inevitable abortion. Now, whether it is inevitable, whether it is incomplete, in both the cases, management is dilatation and evacuation. But please remember that yes, shock is seen with incomplete abortion more commonly. Right? Clear to all of you? Now, in this question, if it would have said 8 weeks uterus, then I would have said it is a case of incomplete abortion. Although here they haven't asked you the diagnosis. They have asked you the management and whether it is incomplete abortion, whether it is inevitable abortion. In both the cases, you are getting that you will have to do a suction and evacuation. Right? And because of bleeding, yes, because of bleeding, you are getting shock. You are right. Clear to all of you? Okay. Coming to the next question. Diagnosis of cervical incompetence is made if length of the cervix and internal os diameters are. So tell me. Length of the cervix. So on one side you have length of the cervix and on the other side you have internal os diameters. So tell me. Diagnosis of cervical incompetence, when are you going to make? If length is less than 2 centimeters and internal os more than 2 centimeters, if length is less than 2.5 centimeters and internal os more than 2 centimeters, if length is less than 2 centimeters and internal os more than 1 centimeter, if length is less than 2.5 centimeters and internal os more than 1 centimeters. So we have varied answers over here. And the confusion is between option B and option D, right? So all of you know that yes, length less than 2.5 centimeters is incompetent os, right? So in cervical incompetence, the length of the cervix is less than 2.5 centimeters. But please remember that the internal os diameter is more than 2 centimeters. More than 2 centimeters is diameter of the internal os in case of cervical incompetence. So the answer over here will be option B. So these are very, very basic MCQs. Sometimes what happens is that we start doing MCQs which are, more towards the difficult side, more clinical, and we tend to forget the single liner questions. And in NEET PG, you should expect single liner questions also, right? So please remember that this is the answer for cervical incompetence. Length of the cervix less than 2.5 centimeters and internal os diameter more than 2 centimeters. That is what is cervical incompetence diagnosis on ultrasound. So on ultrasound, this is how you make the diagnosis of cervical incompetence. Apart from this, there are changes which are going to happen in the shape of the cervix as well. So please remember, normal shape of the cervix is a T-shaped cervix. From T-shaped, it will become Y-shaped. Then it will become V-shaped. And finally, in case of cervical incompetence, it becomes a U-shaped cervix. So in case of cervical incompetence, in U-shaped cervix. Right. Clear to all of you? Now, please remember it is 2 centimeters. There is always a confusion between 1 centimeter, more than 1 centimeter and more than 2 centimeters. I believe that in the marrow Q bank, it has been given as more than 1 centimeter. And that is why specifically I have told you this over here, that the diagnosis of cervical incompetence is more than 2 centimeters dilatation. This is a question which you keep on asking me on marrow links also, and on marrow links also I keep telling you, right? Okay. Now, so many times you are going to confuse the diagnosis of cervical incompetence with diagnosis of preterm labor. Now, please remember that for the diagnosis of preterm labor, it is any of the following three which I am going to tell you along with uterine contractions. So if you are getting length of the cervix less than 2 centimeters, in cervical incompetence it was less than 2.5 centimeters. In preterm labor, if the length is less than 2 centimeters, this is for the diagnosis of preterm labor. Or if internal os diameter is more than 3 centimeters. So in case of cervical incompetence, length less than 2.5 centimeters, dilatation more than 2 centimeters. In preterm labor, length less than 2 centimeters and dilatation more than 3 centimeters, either of these two. Now suppose the length of the cervix is between 2 to 3 centimeters. If length of the cervix is between 2 to 3 centimeters, then if they ask you in the case of preterm labor, if there is a patient who is having uterine contractions and the length of the cervix is between 2 to 3 centimeters, 2.5 centimeters suppose, and they ask you what is the next step. So the next step will be fetal fibronectin protein, because the diagnostic criteria is that if length is between 2 to 3 centimeters and if fetal fibronectin protein is present, then also we say that the patient is having preterm labor. So there are three criteria for diagnosing preterm labor. Number one, length less than 2 centimeters, dilatation more than 3 centimeters, or if length of the cervix on ultrasound is between 2 to 3 centimeters, then you should go for fetal fibronectin protein. And if fetal fibronectin protein is positive, that means it is more than 50 nanograms, then you are going to say that yes, it is a case of preterm labor if uterine contractions are also happening. Clear to all of you? Yes. Now, a very oftenly which you confuse is if they ask you what is the cutoff length of the cervix to predict preterm labor. Now, it is not diagnose preterm labor. To predict preterm labor, the cutoff length is 2.5 centimeters. So the moment cervix becomes 2.5 centimeters, it is to predict preterm labor. That is a high risk that a patient is going to have preterm labor. But I am going to diagnose preterm labor if it becomes less than 2 centimeters, or if it is 2.5 centimeters, then I should get a fetal fibronectin protein done. And if it is positive, that means if it is present, that is more than equal to 50, then I am going to say that yes, it is a case of preterm labor. So to predict preterm labor, it is 2.5. To diagnose preterm labor, it is 2 centimeters. Clear to all of you? Okay. Next question. Next question is a 30-year-old primigravida with 20 weeks of gestation. So she is a primigravida with 20 weeks of gestation. She presents for routine antenatal visit. On ultrasound, cervical length is 2.2 centimeters. What is the next step in management? Now tell me, what is the next step in management? I'm waiting for your answers. Option A, advise cervical cerclage. Option B, do cerclage and give weekly progesterone starting from 24 weeks. Option C, give weekly progesterone injection. Option D, follow her up with monthly ultrasound without any treatment. So I can see all sorts of answers over here. Some of you are saying A, some are saying C, some are saying D, and a few of you have said option B. Right. Now, many of you are saying option C, but there are some of you who are still saying option A and D. So please remember, correct answer is option C here. Let us discuss this question further. Now, in this question, please tell me that this patient is a primigravida patient, right? So she doesn't have any history of abortion. She doesn't have any history of preterm labor, right? The length of the cervix is 2.2 centimeters. Normal length of the cervix in pregnancy is between 3 to 4 centimeters. And if length of the cervix is less than 2.5 centimeters, I'm going to call it as a short cervix. Right. Now, in this patient, if patient would have been saying that uterine contractions are felt, right, and I would have suspected if she would have been more than 20 weeks and she would have said contractions are being felt, then I would have taken it more towards a case of preterm labor. Now, over here, they have not mentioned anything about contractions, and patient is 20 weeks pregnant. 20 weeks pregnant patient with short cervix, without any history of abortions, without any history of preterm labor. Am I going to do a cervical cerclage? No, I am not going to do a cervical cerclage. When do you do a cervical cerclage? First, let us see that. See, prophylactically, you are going to do cervical cerclage either based on history or based on ultrasound. If on history you are getting history of 2 second trimester abortions or very early preterm labor. Very early preterm labor means preterm labor at less than equal to 24 weeks. Right? In that case, there is no need to get an ultrasound done. If there is history of 2 second trimester abortions or a very early preterm labor, in that case, there is no need to get an ultrasound done. In that case, straight away, I would have gone for a cervical cerclage. Right? Or suppose if patient has previous history of one second trimester abortion or just one preterm labor, very early preterm labor, in that case my next step would have been ultrasound, and if on ultrasound cervical length would have been less than 2.5 centimeters, then what would I have done? In that case, yes, I would have gone for cervical cerclage. Right? So based on ultrasound, I am going to do cervical cerclage if there is previous history of one abortion, second trimester abortion, or if there is history of preterm labor. And plus, because the length of the cervix is short, apart from doing cervical cerclage, I will give her progesterone weekly. Right? Now in my question, there is no history of previous abortion, second trimester abortion. There is no history of preterm labor. There is only history of cervical length 2.5 centimeters, less than 2.5 centimeters, that is 2.2 centimeters. So I am going to call it a short cervix, but that does not qualify as a case for doing cervical cerclage. So I'm not going to do cervical cerclage in this case. Right? So what am I going to do now? I am just going to give her progesterone. I am repeating if you've not understood. So I am saying that if your patient has history of 2 abortions, second trimester abortions, or if she has history of preterm labor, very early preterm labor, 2 abortions or 2 preterm labors which are happening very early, then no need for ultrasound, go directly for cervical cerclage. Right? Now, if your patient has history of one second trimester abortion or just one preterm labor, then go for an ultrasound, and on ultrasound, if you get a short cervix, right, then do a cervical cerclage. That qualifies as a case for doing cervical cerclage, and simultaneously start progesterone weekly. Why progesterone weekly? That is because all those patients who have cervical incompetence, they have a risk for having preterm labor as well. And to prevent preterm labor, I'm going to give progesterone weekly. Especially if there is previous history of preterm labor, then I should be giving progesterone weekly to prevent preterm labor in this pregnancy. Right? Now, in this case, the present case we are talking about, there is no history of previous second trimester abortion, no history of preterm labor. Right? So obviously I cannot, and the length of the cervix is short. Now, because there is no history of previous abortion or previous preterm labor, she doesn't qualify to be a case for doing cervical cerclage. But on the other hand, yes, cervix is short. So if cervix is short, she does have a risk for preterm labor, and whenever a patient has risk for preterm labor, the best drug which can prevent preterm labor is progesterone. So in this patient, I am going to give progesterone weekly. Clear to all of you? Yes. So over here, now in this question, suppose progesterone weekly was not given. Right? So yes, I agree to you. All the answers are going to depend upon the options which are given. So suppose progesterone weekly was not given. Over here it was given advise cervical cerclage, do cerclage and give weekly progesterone. Follow her up with monthly ultrasound without any treatment. And option C is any other option. Suppose it was you should give antibiotics. Any other option. Now in this case, what, because progesterone weekly was not given, so now my answer will be option D. So depending upon the options which are given to you, your answer you have to give. So yes, I am not going to do a cervical cerclage, but because the length of the cervix is short, it is better you give progesterone, and if giving progesterone is an option, then I'm going to go for that option. If giving progesterone is not an option, then I'm going to go for option D, which is follow her up with monthly ultrasound. I hope all of you understood. Yes? So always your answers, that is why I always tell you, please don't mug up the answer. Mug up the, understand the concept. If your concept is clear, then whatever options are given, you can always change your answer depending upon the options. I hope you are understanding now, all of you. Yes? Okay. Then, question number 4. Now, this question number 4 and question number 5, they are based on same concept. And question number 5 was a question which was asked in your previous year NEET. Right? So, this is a repeat from previous year NEET. Right? Now comes, no, it's not going to be tough. Don't worry. Don't worry, bachcho. It is not going to be tough. Only concept you have to understand. The concept is that when you should do a cervical cerclage. So you all know when you should be doing a cervical cerclage, when you should be doing cerclage based on history, and when you should be doing cerclage based on ultrasound. Right? Now, if your patient is not qualifying for cerclage, then and if the cervix is short, that means she has chances increased risk for preterm labor, and in that case better answer is giving progesterone. If giving progesterone is not given, then the better answer is going for monthly ultrasounds. Clear? Okay. Now, a 35-year-old G3P0 has history of 3 previous first trimester abortions. 3 previous first trimester abortions. The least possible cause of her abortion is option A, syphilis, option B, balanced translocation of chromosomes, option C, APLA, option D, endocrine causes. Okay, I can see various answers. Actually, I don't know whether you are a subscriber of Marrow or not. So if you can, when you are giving me the answer, please, if you can tell me whether you are a Plan C subscriber or not. Because I just want to see how you people are answering these questions. All Plan C Marrow subscribers, I want to see how are you answering. What answers you are giving. Komal, very good. You've written. Ayub, very good. Suvana, your answer is also right. So the answer over here is syphilis. Now understand, I have told in your Marrow notes as well, in the Marrow videos also, that syphilis follows Kazowitz law. But before that, let's go to very basic things first. How do you define recurrent abortion? Recurrent abortion is if there are 3 or more than 3 abortions which are happening at less than 20 weeks. Right? 3 or more than 3 pregnancy losses which are happening at less than 20 weeks. That is what is your definition for recurrent abortion. When do you start evaluating a patient for recurrent abortion? The moment 2 abortions happen, you start evaluating the person for recurrent abortions. What is the most common cause for recurrent abortion? What is the most common cause for recurrent abortion? Please tell me. Most common cause for recurrent abortion? Most common cause, if you are seeing as a group, the most common cause is uterine causes. Uterine causes are going to include uterine anomalies. Uterine causes are going to include your cervical incompetence. Uterine causes will include fibroid uterus, right? But then if you are asked single cause, very good Plan C users. Very good. I can see your answers. Okay. Now, if I ask you what is the single most important cause? Single cause. One single cause which is the most common for causing recurrent abortion. Tell me quickly. Single most important cause. The single most important cause is APLA. Right? Clear to all of you? So uterine causes as a group, yes, it is the most common. But as a single most important cause, it is APLA. Now the established causes for recurrent abortions. What are the 4 established causes for recurrent abortion? All Plan C users quickly write and tell me 1, 2, 3, 4. Established causes of recurrent abortion. 4 established causes for recurrent abortion. ठीक है, idiopathic we are not considering. 4 established causes for recurrent abortions. What are they? Tell me. Number 1, uterine anomalies. Number 2, APLA. Number 3, endocrine causes. Number 4, see, idiopathic will never be given to you in the options. Single most important cause is APLAS. Idiopathic, they will never give you in the options. Right? So, number 1, uterine anomalies. Number 2, APLA. Number 3, endocrine causes. And which is the 4th established cause for recurrent abortions? Fourth established cause. Baba, idiopathic will never be given to you in the options. If they ask you single most important, then it is APLA. 4th established cause, tell me quickly. I have written 3 for you. Uterine anomalies, APLA, uterine anomalies, APLA, endocrine causes. Cervical incompetence comes in uterine anomalies. And yes, very good, Mona. It is balanced translocation of chromosomes, and that is chromosomal anomalies. Right? So these are the 4 established causes for recurrent abortions, and that is why the investigations which should be done in a patient of recurrent abortions are: for uterine anomalies, you are going to do ultrasound; for APLA antibodies; for endocrine causes, TSH and GTT, that is the blood sugar levels; and for chromosomal anomalies, karyotyping. So these are the investigations which I am going to do in a patient for recurrent abortions. Now, chromosomal anomaly which can lead to recurrent pregnancy loss, it is balanced translocation of chromosomes. Balanced translocation of chromosomes. Please do not say aneuploidy. Aneuploidy is the answer for single abortion. Most common cause for single abortion or an isolated case of abortion, whether it is happening in first trimester or second trimester, it is aneuploidy. But for recurrent abortion, the chromosomal anomaly which leads to recurrent pregnancy loss, it is balanced translocation of chromosomes. Infections, they do not lead to recurrent pregnancy loss. As far as syphilis is concerned, it follows the Kazowitz law. And I told you that Kazowitz law means that as the number of pregnancy losses are going to increase, the period of gestation at which the loss is going to happen will also increase. So yes, syphilis can lead to first trimester or second trimester abortion, one first trimester or second trimester abortion, and next time it will not be an abortion. Next time a patient of syphilis, when she will conceive, she is going to have a stillbirth. Next time she is going to have a fetus, live fetus with congenital anomalies. So that is how it is going to happen. So a patient of syphilis can never have early recurrent pregnancy losses. You will never get a history of 3 first trimester abortions or 2 first trimester abortions or 2 abortions in patient of syphilis. First time she is going to have an abortion. Next time she is going to have a stillbirth. Next time she is going to have a live fetus with congenital anomaly, or it could be that if stillbirth happened at 32 weeks in one pregnancy, next time it is going to happen at 38 weeks. So that is what is Kazowitz law, that as the number of pregnancy losses increase, the period of gestation at which the loss is going to happen will also increase. So in patients of syphilis, this kind of history, that there is 3 previous first trimester abortions, is never going to happen, right? So syphilis is the least possible cause for her abortions. Balanced translocation of chromosomes, yes, it can lead to recurrent pregnancy loss. APLA can lead to recurrent pregnancy loss. Endocrine causes can lead to recurrent pregnancy loss. But syphilis is never going to lead to such kind of pregnancy loss, where the pregnancy losses, 3 pregnancy losses, are happening in first trimester. That is not going to happen, right? So over here, yes, This is what your answer is, syphilis. And all of you are right. Infections never lead to recurrent pregnancy loss. So you are never going to get a torch infection test done. Right? Clear to all of you? Yes? Any confusions over here? Now, if you don't have any confusions over here, now read this question now carefully. This is your previous NEET question, which is saying that a 30-year-old G4P3 had first pregnancy loss at 8 weeks, second at 11 weeks, and a third preterm labor due to early onset preeclampsia. Right? Diagnosis is. Now, in this case, you are having first pregnancy loss at 8 weeks, that is first trimester loss. Second pregnancy loss at 11 weeks, that is again a first trimester pregnancy loss, and then a preterm labor. Now, tell me, can a patient of syphilis have this kind of history? No. So, here the confusion is between APLA and syphilis. Torch infections are not going to lead to recurrent pregnancy losses. GDMA, you don't get a history like this. So, either it has to be APLA or syphilis. But in syphilis, you are not going to get history of 2 abortions. You can get history of 1 abortion, but not history of 2 abortions. So, it cannot be syphilis. Are you understanding? First pregnancy loss at 8 weeks, that is first trimester. Second pregnancy loss at 11 weeks, which is again first trimester. And then a third preterm labor. This kind of history you do not get in syphilis. In syphilis, you are going to get one history of abortion, which is going to happen at less than 20 weeks. Then you are going to get history of stillbirth, which may happen at any weeks of pregnancy. And then you are going to have history of maybe a preterm labor, or you are going to have history of a live baby with congenital anomalies. So this is not a case of syphilis. Another thing which over here typically tells you it is a case of APLA, because they are saying that this patient had early onset she had preterm labor due to early onset preeclampsia. So we have modified Sapporo's criteria, which is used for diagnosing APLA, which is also called as Sydney criteria. Now, according to this modified Sapporo's criteria, any one clinical criteria and any one lab criteria should be fulfilled. And what is the clinical criteria? If patient has history of thrombosis, which could be arterial or venous thrombosis. Number 2, if she has one or more unexplained pregnancy loss, which is happening at more than 10 weeks, right? So, one or more pregnancy loss at more than 10 weeks, then one or more preterm labor, which is happening either due to uteroplacental insufficiency or it is happening due to PIH. So, one preterm labor which is happening due to uteroplacental insufficiency or PIH, one or more. And number 3, 3 or more pregnancy losses which are happening at less than 10 weeks. So, 1 or more at more than 10 weeks, 3 or more at less than 10 weeks, or 1 preterm labor which is happening either due to PIH or uteroplacental insufficiency. Plus, along with that, you should have the lab criteria, and lab criteria says any of the antiphospholipid antibodies should be present, which could be lupus anticoagulant or anticardiolipin antibody or anti-beta-2 glycoprotein antibody present on 2 occasions. They should be present on 2 or more occasions 12 weeks apart. So, if you have one lab criteria and you have one clinical criteria, then you make a diagnosis for APLA, right? Now, in this question, the problem was that in this question, you were having one abortion at less than 8 weeks, one abortion at more than 8 weeks, one abortion at 11 weeks. That is more than 10 weeks pay, you are getting one abortion. Right, so one criteria fulfilled, clinical criteria. There is another clinical criteria which is getting fulfilled, that there is history of one preterm labor which is happening due to early onset preeclampsia. So there are 2 clinical criteria which are getting fulfilled for APLA. The only problem over here is they have not mentioned anything about antibodies are present or not. They haven't given you any lab criteria, but 2 clinical criterias are getting fulfilled. So this is a question which is going in favor for APLA rather than syphilis. Are you understanding? So answer over here is syphilis. Option D, that is option C, that is APLA. It is not option D, that is syphilis. It is option C, APLA. Clear to all of you? Any confusions over here? It is not syphilis, because in syphilis you will not get history of 2 first trimester abortions. Right. Now, in management of APLA, how do you manage APLA? If APLA is happening in pregnancy. Now, if APLA is happening in pregnancy and patient has history of either abortion or she has history of thrombosis, in this case, I am going to give her aspirin plus low molecular weight heparin. Aspirin I am going to start as soon as pregnancy is diagnosed, and low molecular weight heparin I am going to start when I am sure that it is a case of intrauterine pregnancy. Right? So aspirin as soon as urine pregnancy test comes out to be positive, and low molecular weight heparin when I am sure that it is a case of intrauterine pregnancy. Now suppose there is a patient of APLA who has no history of abortions. She has no history of thrombosis. Right? The diagnosis of APLA is made based on the history of preterm labor, plus yes, antibodies are present. Now, if there is no history of abortion and no history of thrombosis, and only the diagnosis is being made based on the history of preterm labor, there is no history of abortion, no history of thrombosis. In this case, what am I going to do? In this case, I am not going to give low molecular weight heparin. In this case, I am going to give only aspirin. Clear to all of you? So that is how you manage APLA. Please remember modified Sapporo's criteria, that is very, very important. It is also called as Sydney criteria, that is also very important. Cervical incompetence and when you have to do cervical cerclage, APLA, all these are very important not only for your upcoming NEET exams but also for INI set exams. Now coming to question number 6. Now this was a question which was asked in MCI. Dr. Shubham, lab criteria pura nahi hua. That is what I am saying. Ki over here they have not mentioned anything about lab criteria, but still I am going to call it as APLA and not syphilis, because in syphilis you are not going to get this this kind of picture. Right? Yes, lab criteria is not getting fulfilled because they have not mentioned anything about lab criteria. So over here, that is why last year students were in a lot of confusion whether to mark it as syphilis or whether to mark it as APLA. So yes, this is a case of APLA. This is not a case of syphilis. Right? All of you? Okay. Now look at this question. A G3P2 presents with 8 weeks pregnancy for MTP. What number of the instrument shown in figure should be used? So first identify this figure. What is this instrument which is being used? This instrument which is being used is Karman's cannula, and Karman's cannula is used during suction evacuation. Please remember that suction evacuation is the best method for doing MTP between 7 to 12 weeks. Up till 7 weeks, the best method for doing MTP is medical abortion. And this medical abortion you are going to do using mifepristone and misoprost. Right? This over here is done on outpatient basis or as an OPD patient basis. Between 7 to 12 weeks, the best method is suction evacuation. In rural areas where electricity is not available, where suction evacuation cannot be done, you are going to go for manual vacuum aspiration. In second trimester, the best method is misoprost. That is again, it is medical abortion. But this medical abortion is done on IPD basis. Right? So you are going to do using IPD. Now in Carman's cannula, you have to remember that the number on the Carman's cannula, it corresponds to the diameter of the cannula in millimeter, and the size of cannula which you are going to use, it will be equal to the duration of pregnancy in weeks. So if over here the question is saying that it is 8 weeks pregnancy, then the size of suction evacuation cannula which you are going to use will be 8. Right? So you are going to use 8 number Carman's cannula. Just in case, the number of cannula is not matching. The option is such that in the option, the number of cannula and the period of gestation in weeks is not corresponding. So suppose it would have been given over here 11 weeks. Right? And in the options, you had 8 weeks, 9 weeks, 10 weeks, 8, 9, 10 and 12. You had 8, 9, 10 and 12 in the options. Now in that case, I would have marked the answer as 10. Because either it has to be equal to the period of gestation, which is the best. But if it is not equal to the period of gestation, then 1 less. Clear to all of you? Okay. Now, as I told you, suction evacuation, it is done by using Carman's cannula. The pressure which is generated while you are doing suction evacuation is 600 millimeters of mercury. And before you insert Carman's cannula, you will have to dilate the internal os, and you are going to dilate the internal os using Hagar's dilators. Right? And then you are going to introduce Carman's cannula for doing suction evacuation. Now, when I am doing suction evacuation, it could be that perforation of the uterus happens. That is a rare complication, but that may happen. Now, if perforation is happening while you were dilating with Hagar's dilators, then what is the next step? Then the next step is you have to just observe the patient. Right? You have to just monitor the patient or observe the patient. You have to see her vitals and just monitor her. But if perforation happened with Carman's cannula, then what are you going to do? Then immediately you are going to stop the procedure. With Hagar's also you are going to stop the procedure, but then after stopping the procedure, you are just going to monitor the vitals, nothing else. But if perforation is happening with Carman's cannula, you are going to stop the procedure there and then. You are not going to remove. Do not remove Carman's cannula. So you are not going to take out Carman's cannula. Let the Carman's cannula be inside and immediately take the patient for laparotomy. Clear to all of you? So this is what you do if perforation happens while you were doing suction evacuation with Carman's cannula. Now, as I told you, in rural areas, you may use a method which is called as manual vacuum aspiration. In manual vacuum aspiration is done with the help of this syringe, and this syringe is an MVA syringe. How are you going to identify this syringe? Because in this syringe you have got 2 pinch valves. So if 2 pinch valves are present, that is how you identify MVA syringe. Now the question which they ask you is manual vacuum aspiration, what is the pressure generated? So please remember, the best answer to the pressure generated by manual vacuum aspiration is 660 millimeters of mercury. If 660 is not given, then the second best answer is 600 millimeters of mercury. And the syringe, what is the capacity of the syringe? The capacity of the syringe is 60 ml. Right? So 660 is the pressure generated and 60 ml is the capacity of the syringe. Clear to all of you? Okay. Menstrual regulation syringe. Menstrual regulation syringe, all this has been given in a video which is called as Instruments in Obs and Gynae, and I've told you in a menstrual regulation syringe, you will have a single valve, number 1. Then a menstrual regulation syringe is a 50 ml syringe, again a very important point. And menstrual regulation, it is done up till 6 weeks of pregnancy, whereas manual vacuum aspiration is done between 7 to 12 weeks of pregnancy. It is an alternative to suction evacuation. Menstrual regulation can be done only up till 6 weeks of pregnancy. So that's the difference between menstrual regulation syringe and manual vacuum aspiration syringe. That is very, very important. Now, another instrument which you can use for doing MTP or for doing abortions, that is your ovum forceps. Ovum forceps is used for doing dilatation and evacuation in second trimester. So when you want to do suction dilatation and evacuation in second trimester, then you are going to use ovum forceps. Ovum forceps, the proximal end is spoon shaped, right? And it does not have any lock. Although this is a forceps, this does not have any lock. So this is unique about ovum forceps, right? So this image is again very, very important image. Clear to all of you? Okay. Coming to the next question. A 26-year-old female with 5 weeks of amenorrhea with history of spotting PV. Her urine pregnancy test is positive, right? TVS shows empty uterus and no fluid in the pouch of Douglas. What is the next line of management? Now tell me. She is 5 weeks amenorrhea, plus she has spotting PV, plus UPT positive, right? So over here, what are you thinking? I am thinking that this could be a case of ectopic pregnancy, right? Or it could be a case of abortion, right? Or it could be a case of early intrauterine pregnancy, right? Now, over here on ultrasound, you are getting empty uterus. Empty uterus. So when you are getting empty uterus in early weeks of pregnancy, these are the three differential diagnoses which you have in your mind. Now what am I going to do? Now if I have these three differential diagnoses in my mind, how am I going to know whether it is a case of ectopic pregnancy, whether it is a case of abortion, whether it is a case of early intrauterine pregnancy? Now, in this case, the next step should be that you should follow it up with HCG, serial beta HCG values, right? Because if it is a viable intrauterine pregnancy and you did ultrasound at an early age, at that stage when gestational sac is not visible, in that case, what is going to happen? You are going to see that the values of HCG will double in 48 hours. Even if they do not double, they will become more than 66%. They will be increased by more than 66% in the values of HCG, right? Whereas if it is a non-viable intrauterine pregnancy, abortion, then what are you going to see? You are going to see that the HCG levels will drop. If it is a case of ectopic pregnancy, in ectopic pregnancy, you will get a slow rise in HCG. So HCG will increase, but it will not double in 48 hours. It will not become more than 66% in 48 hours. There will be a slow rise in HCG levels. So if I am getting that it is a case, I am in doubt whether we are dealing with ectopic pregnancy, whether we are dealing with abortion, or whether we are dealing with an early intrauterine pregnancy, next step is follow up with beta HCG. Now, why is it not culdocentesis? Culdocentesis should have been done if they would have said that it is a case of ruptured ectopic, that is fluid is present in pouch of Douglas. Now, over here they are telling you fluid is absent in pouch of Douglas, so obviously there is no use for doing culdocentesis. I am not going to manage unless and until I am sure whether I am dealing with abortion or whether I am dealing with ectopic pregnancy, right? Now, what is the critical value of HCG for TVS? In a TVS, what is the critical value for HCG? That means that value of HCG at which 100% in a case of in a case of intrauterine pregnancy, you will see a gestational sac. That particular value of HCG, above which you are going to see a gestational sac on ultrasound in case of intrauterine pregnancy. So what is that value? I have got varied opinions. So yes, you are right. It could be 1500, it can be 2000, but most commonly the value which is taken is 1500 international units. Right? Different texts say different values, but 1500 international units. Right? Then on TAS, 6500 international units. Right? Clear to all of you? Okay. Now, this over here is an image which is showing you cultosynthesis. This over here is an image of cultosynthesis. In this, what you are seeing that a syringe is being taken into the pouch of Douglas via the posterior fornix, and you can see fluid coming out, right? And what is image B showing you? Image B is showing you ring of fire sign. Please remember, if they ask you the diagnostic of ectopic pregnancy on ultrasound. So what is diagnostic of ectopic pregnancy on ultrasound? It is extrauterine gestational sac with an embryo or yolk sac. So if you are getting a gestational sac or a yolk sac or an embryo, then that is diagnostic of ectopic pregnancy on ultrasound. Ring of fire appearance is not diagnostic of ectopic pregnancy. It is just suggestive of ectopic pregnancy. Yes. So, one second. Yes, you all are right. I'm so sorry. This is 2000. This is 2000. This was the update. Yes, it is 2000. All of you are right. I'm sorry for the goof up. 2000. Baba, nahi, no gadbad, nothing gadbad. It is 2000 international units. Yes, I have told you to change. It is 2000. Yes, sorry, it was 2000. It was my mistake. It is not 1500. Yes, all of you are right. It is 2000. All of you are right. It is 2000. It is not 1500. Sorry for that goof up. It is 2000. Right? Clear? It is 2000. Don't worry. No gadbad over here. Nothing. It is 2000. Right? Okay. You know what is happening is I am taking a live class like this for the first time. So on my one hand, I have my mobile where I am reading what you people are writing. And over here, so many times I am speaking what you people are writing here. So it will take me a little more time to get accustomed to live classes like this, where I have something written over here and I am speaking also. So most of the time I'm just seeing over here, and my mind, I'm not thinking from my mind, and I'm just speaking what I'm seeing over here, right? So sorry. Yes, you all are right. It is 2000. Okay, it give me a little more time. I'll get accustomed to live classes like these, where I can read your answers, and I can say what I want to say at the same time. Okay, question number 8. Which of the following is an indication for surgical management of ectopic pregnancy? Now, again, this is a previous FMG question which came, and I want all of you to answer this question quickly now. Which of the following as an indication for surgical management of ectopic pregnancy? So it is option A. All of you are answering it correctly. So now tell me, let's quickly revise. Medical management, what is the absolute criteria? The absolute criteria for medical management is it has to be an unruptured ectopic, number one, and free fluid should be less than 100 cc. Now, the relative requirements for ectopic pregnancy are HCG value less than 5000 international units, size of the ectopic less than 4 centimeters, cardiac activity should be absent, and there should be absent or minimal pain. Now, these are relative criteria for medical management of ectopic pregnancy. Now over here I want you to please remember that if cardiac activity is present, then it doesn't mean that medical management cannot be done. If cardiac activity is present, medical management can be done because presence or absence of cardiac activity is just a relative requirement. It's not an absolute requirement, right? But then if I am going to do medical management, if cardiac activity is present, then the chances of medical management getting fail will be more. Number one. Number two, so if cardiac activity is present and if they ask you what is the best management, then please remember if cardiac activity is present, then the best management is surgical management. Similarly, if size of ectopic pregnancy is more than 4 centimeters, best management is surgical management. If HCG values are more than 5,000, then the best management is surgical management. Right? Now, if suppose I am doing medical management and cardiac activity is present, although this is not preferred, but in that case, the size of the ectopic should be less than 3.5 centimeters. Then only you can do medical management if cardiac activity is present. But that doesn't mean that if cardiac activity is present, best management is medical. No. If cardiac activity is present, best management is surgical management. Right? Now suppose if your question is just talking about unruptured ectopic pregnancy and they ask you what is the overall best management. Overall best management for unruptured ectopic pregnancy is medical management. It is not expectant management. Right? And if they ask you that for a ruptured ectopic pregnancy, what is the best management? The best management is surgical management. And what surgery am I going to do? I'm going to go for salpingectomy, irrespective of the fact whether the family is complete or not. Even if the family is not complete, if it is a case of ruptured ectopic, you will have to do salpingectomy. You are going to open the abdomen by laparotomy. You can go for laparoscopy if vitals are stable. But most of the times in ruptured ectopic, vitals will not be stable. And so you are going to go for laparotomy. And after laparotomy, you are going to remove the damaged tube, whether the patient's family is complete or not. Right? Now, if your question is saying that there is an ectopic pregnancy in a female with decreasing values of HCG, they have given you two values of HCG. Both the values of HCG are less than 1000 international units, and over a period of time, the values are decreasing. Then if they ask you what is the best management, then best management is expectant management. Only if they have given you this, that the values of HCG are decreasing. In other words, they give you two values of HCG and they give you that the values of HCG are decreasing. If they ask you what is the best management for heterotopic ectopic pregnancy. For heterotopic ectopic pregnancy, heterotopic means a twin pregnancy in which one is intrauterine and the other one is your ectopic pregnancy. So for heterotopic ectopic pregnancy, best management is surgical management. Obviously, if she wants to keep the intrauterine pregnancy, I cannot give her medical management. Surgical management. Right? Now suppose your question like over here. Over here there is saying which of the following is an indication for surgical management of ectopic pregnancy. So ectopic mass size more than 4 centimeters is an indication for surgical management of ectopic pregnancy. Now in unruptured ectopic pregnancy, what is the surgery of choice? In unruptured ectopic, if family is complete, then I am going to go for salpingectomy. But if family is not complete, I am going to go for linear salpingostomy. Linear salpingostomy. Clear to all of you? And over here, I am going to prefer laparoscopy over laparotomy. Right? Now, suppose your question is saying that there is an ectopic pregnancy in a female with absent cardiac activity, HCG values 3000 international units and size 3 centimeters. Now, because HCG is less than 5000, because cardiac activity is absent and because size is less than 4 centimeters, you will say that ma'am had said that we are going to go for medical management. But please read your question carefully. The question further says that the patient's family is complete. Now, if this line is added that patient's family is complete, then please do not say that I'm going to go for medical management. Now I am going to go for surgical management. Clear to all of you? Question further, read this line, patient's family is complete. So now I'm going to prefer surgical management over medical management. Clear? That is why I am giving you over here this question, because otherwise you would have told that ma'am has said medical management. Because the question is saying that patient's family is complete, so you are going to go for surgical management instead of medical management. Right? Clear to all of you? Yes, you are. Yeah, and in surgical management, because family is complete, I will go for salpingectomy, no doubt. Clear? Okay. Next question. A 30-year-old female who was treated for infertility with 6 weeks of amenorrhea comes with abdominal pain and mild vaginal bleeding. Her beta HCG level is 2800 international units. On ultrasound, left adnexal mass of 3 centimeters is seen. A gestational sac with no fetal cardiac activity is seen. What is the appropriate management? Now, over here, they haven't said that the family is complete. Right? Over here, they haven't said that the family is complete. So over here, what is your answer going to be? Over here, your answer is going to be medical management. And with which drug are you going to do medical management? You are going to do medical management with methotrexate. Now, whenever you are using methotrexate in ectopic pregnancy, you use a single dose methotrexate treatment. That means the entire dose which you are going to calculate, you are going to give it on day 1. Then on day 1, I will give methotrexate. On day 4, I am going to measure HCG levels, and day 7, I am going to measure HCG levels. And suppose if the decrease in HCG levels is less than 15%, on day 7 in comparison to day 4, then I'm going to repeat the entire cycle. This is not what is called as multi-dose methotrexate. Multi-dose methotrexate means you are giving methotrexate, the amount of dose which you've calculated, you are giving it on alternate days. That whatever dose you have calculated, you are giving it on day 1, then day 3, then day 5, then day 7. That is not what you do in ectopic pregnancy. You give multi-dose methotrexate in molar pregnancy, that is in choriocarcinoma, not molar pregnancy, in choriocarcinomas, right? So over here you give single dose methotrexate treatment, and the answer over here will be single dose of methotrexate. If the question would have said family complete, then I would have said salpingectomy. Right? And I am not the one who's going to decide whether patient's family is complete or not. It is the patient who's going to decide. So unless and until they write that line, patient doesn't desire of pregnancy in future, till that time my answer will be medical management. The moment they give this line that the patient's family is complete and she doesn't want any pregnancy in future, then I change my answer to surgical management. Is that clear to all of you? Yes? Any any confusions over here? Okay. Now read this question, question number 10. Question number 10 is a 45-year-old woman. Again, this is a previous year NEET question. This question was also a NEET question. This is also a NEET question. A 45-year-old woman who had undergone dilatation and curettage for molar pregnancy 6 months ago presents with persistent symptoms of abdominal pain and distension. On further investigations, she had persistently elevated beta HCG, 10,000 international units, and cannonball foci were found on chest x-ray. What is the appropriate management in this case? Now, over here you are seeing that cannonball foci are present on chest x-ray. That means it has become a lung metastasis, and that means it is a case of choriocarcinoma. Right? And whenever lung metastasis is present, it means it is stage 3. Now, there are two very important things which you have to understand in choriocarcinomas. One is the stage, which is FIGO staging, and another is WHO risk factors, risk score. Now, in staging, if disease is confined to uterus, that is stage 1. If it extends outside the uterus, but it is limited to the genital tract, then that means it is stage 2. If it spreads to lungs, that is stage 3, and any other metastatic site, that is stage 4. Right? Now, in case of stage 1 FIGO, if it is stage 1 choriocarcinoma, it is always taken as a low risk choriocarcinoma, and always the management is single drug chemotherapy, and that single drug will be methotrexate. Now, if it is stage 4, it is taken as high risk choriocarcinoma, and always management is multi-drug chemotherapy. Right? Now, if it is stage 2 or stage 3, then it could be low risk or it could be high risk. And how am I going to decide? I'm going to decide this based on WHO score. If WHO score is less than equal to 6, it is low risk. If it is more than equal to 7, it is high risk. If it is less than equal to 6, I am going to give single drug chemotherapy. If it is more than equal to 7, I am going to give multi-drug chemotherapy. Now, in this case, patient is stage 3 choriocarcinoma, because cannonball foci are present in the lung. So lung metastasis has happened. So she is stage 3 choriocarcinoma. Now I have to see whether she is low risk or whether she is high risk. And how am I going to know whether she is low risk or whether she is high risk? I'm going to do a WHO scoring system. Now in WHO scoring system, if age of the patient is less than 40 years, she is low risk. Right? If it is more than 40 years, I will give 1 mark. So my patient is, in this question, the patient is 45 years. Right? So I am going to give 1 mark to her. Right? Antecedent pregnancy, if it is molar pregnancy, it's a low risk. So over here, it was a molar pregnancy. So no marks for that. Interval between the antecedent pregnancy. Now, in this case, the question is saying 6 months previously, she had a molar pregnancy which was evacuated. That means, again, 1 mark. And HCG values which they have given you are 10 to the power of 3. So again, 1 mark. Right? And they have said it is lung metastasis. So again, 0 marks for that. So that means her WHO score has come out to be 3. And a score of 3 is a low risk, and that means you have to give her single dose chemotherapy. Clear to all of you? Yes. So you are going to give her single dose chemotherapy. And as I told you, chemotherapy, when you are giving single drug chemotherapy, this is single drug chemotherapy. This single drug is methotrexate. And how do you give methotrexate? You give methotrexate on day 1, day 3, day 5 and day 7, and you alternate it with folinic acid. So this is what is you are going to do over here. That is methotrexate with folinic acid. Right? Emaco regime is multi-drug which you give in case of high risk. And high risk means score of more than equal to 7. Clear to all of you? Or if it is a stage 4 choriocarcinoma. So over here it is stage 3. I will have to see whether it is low risk or whether it is high risk. And as we calculated, she's a case of low risk. Clear to all of you? And in low risk, you will have to give methotrexate. Please remember, in ectopic pregnancy, it is a single dose methotrexate. In case of choriocarcinoma, it is multi-dose methotrexate. You will give methotrexate on day 1, day 3, day 5 and day 7. Clear? So this over here is, they can give you this image. This image is a snowstorm appearance which you are getting on ultrasound. Clear to all of you? Yes? Next question. The marker of development of choriocarcinoma after treatment of complete mole by suction evacuation are all except. And just now we have dealt with questions related to abortion, ectopic and molar pregnancy. And we are at 1.5 hours. So my session is going to end. I am going to take up questions on antepartum hemorrhage, postpartum hemorrhage, and management of third stage of labor in the next session, right? And that next session, probably it is going to be either tomorrow or day after tomorrow. So this is the last question for the day. Now tell me the answer to this question. The marker of development of choriocarcinoma after treatment of complete mole by suction evacuation are all except option A, persistent theca lutein cyst, option B, plateau HCG, option C, suburethral nodule, option D, subinvolution of the uterus. So I can see various answers. Some of you are right. Yes, some of you are right, but some of you are not right as well. So, okay. So let us talk about signs and symptoms of GTN. That is gestational trophoblastic neoplasia after H-mole evacuation. Now, there are certain signs and symptoms and there are certain lab criteria which tell you that yes, GTN has happened. And what are the signs and symptoms? The signs and symptoms are if patient has persistent bleeding after suction evacuation, if there is persistent theca lutein cyst, if there is subinvolution of the uterus, if patient goes into shock, or if there are signs of metastasis. Signs of metastasis are on lungs, you will get cannonball appearance. That's the most common appearance which you get in choriocarcinoma on chest x-ray. Or you can get a snowstorm appearance. On chest x-ray, in vagina, you can get a suburethral nodule. Please remember, metastasis is seen in choriocarcinoma. It is not seen in invasive mole. Right? Invasive mole is a locally malignant tumor. It will not metastasize. Now, if they ask you what is the most common GTN which occurs after molar pregnancy or after molar evacuation, it is invasive mole. Right? The most common GTN after molar pregnancy is invasive mole. Right? Now, lab criteria which tells you that GTN has happened is if you are getting increasing HCG values for 3 weeks. Now, after you do suction evacuation of molar pregnancy, you follow it up with weekly beta HCG values. So, in 3 weeks, if for continuously for 3 weeks, if you are getting increasing HCG value, and how much increased? More than equal to 10% increased. So, you did HCG on day 1, then on day 7 and on day 14, and you are getting that on these days when you did HCG levels, the HCG levels were increasing. Right? If you are getting HCG values increasing, this is more a sign of choriocarcinoma than of invasive mole. So this is more common in choriocarcinoma than invasive mole. Second is plateau HCG value for continuously 4 weeks. So you did on day 1, day 7, day 14 and day 21. And continuously for 4 weeks you were getting values plus minus 10% of the previous values. This goes more in favor of invasive mole than in favor of choriocarcinoma. Or if you are getting HCG values high even after 6 months of evacuation, or if the histopathology which you had sent, the report is showing you that yes, GTN is present. So these are the findings which tell you that GTN has developed. Now your question is, they are asking you, marker of development of choriocarcinoma. So please remember, persistent theca lutein cyst, it is a marker. Suburethral nodule, yes, it is a marker of metastasis. Subinvolution of uterus, yes, it is a marker of choriocarcinoma or any kind of GTN. But when we talk about plateau HCG value is more common with invasive mole than with choriocarcinoma. So if I have to choose one option which is not, they have said all except, my answer will be option B. Have you understood? Now, suppose I change this question. I say the marker of development of invasive mole after treatment of complete evacuation by suction evacuation are all except. Now tell me, now what will your answer be? Now what is your answer going to be? I've just changed that word from choriocarcinoma to invasive mole. Now what will your answer be? Are all except. Now your answer is going to be suburethral nodule. All of you are right, because suburethral nodule means metastasis. And metastasis is seen in choriocarcinoma. It is not seen in invasive mole. Right? Invasive mole is a locally malignant tumor. Now suppose I change from plateau HCG, I put it as increasing HCG. Option B is increasing HCG. Now tell me same question about invasive mole. Now tell me what will your answer be? I have changed your option. From plateau HCG, I have done it to increasing HCG. Now tell me your answer. Will you still say that it is C, or now are you going to mark it as B? Will you say C or will you mark it as B? Tell me quickly. I'm waiting for all of you to answer. Now, if this is the question, so increasing HCG is more characteristic of choriocarcinoma, but it can be seen in invasive mole, right? But metastasis is never seen in invasive mole. So again, my answer will remain option C. Are you understanding that depending upon the options, you will have to choose your answer? So if it is increasing HCG, my answer still remains suburethral nodule, because metastasis is never seen in invasive mole. You may get increasing HCG in invasive mole, although increasing HCG is more characteristic for choriocarcinoma. But still your answer will remain suburethral nodule. Now quickly, I am telling you just 3 single liner questions which you have to tell me. Most common GTN after molar evacuation. If they ask you this, it is invasive mole. Choriocarcinoma most commonly occurs after. If they ask you this, then it is molar pregnancy. Right? High risk choriocarcinoma most commonly occurs after. So choriocarcinoma is a high risk choriocarcinoma if it is happening after term pregnancy, right? So high risk choriocarcinoma occurs after full term pregnancy, right? If they ask you after full term pregnancy, most common GTN. What is the most common GTM which happens after full term pregnancy? So after full term pregnancy, the most common GTN which happens is choriocarcinoma. But if they ask you PSTT, placental site trophoblastic tumor, occurs most commonly after. So placental site trophoblastic tumor occurs most commonly after full term pregnancy. So these are some single liners which you will have to remember about GTNs, right? Now, what are those GTNs for which you have to do hysterectomy, where you cannot go for chemotherapy? They are PSTT and epithelioid trophoblastic tumors. Where else do you do hysterectomy? In case of invasive mole, if there is excessive hemorrhage, then you are going to go for hysterectomy, or while you are doing molar evacuation if there was excessive hemorrhage. Or in molar pregnancy, if the female is more than 40 years plus her family is complete and she has a complete mole, then I go for hysterectomy. So if they ask you what are the indications for doing hysterectomy in a molar pregnancy or in GTNs. So in GTNs, the indication for doing hysterectomy are PSTT, placental site trophoblastic tumor, epithelioid trophoblastic tumor. While I was, trying to give chemotherapy for invasive mole, and if there is excessive hemorrhage or patient goes into shock, because the invasive mole goes deep inside the myometrium and patient goes into shock while the patient was on chemotherapy, then that is an indication for doing hysterectomy. Or if patient is more than 40 years, her family is complete and she's a case of complete mole, then it is an indication for doing hysterectomy. Otherwise, for invasive moles and for choriocarcinomas, the best treatment is chemotherapy. For molar pregnancy, the best management is suction evacuation. Only if your question is saying female more than 40 years, family complete and complete mole, then you are going to say that I'm going to go for hysterectomy. Have you understood this? Yes, beta, Abhijit, understand. Plateau HCG can be seen in choriocarcinoma as well, but it is more common in invasive mole, right? That is what I have made you write. It is more common in invasive mole followed by choriocarcinoma. So if your question was the original question which I had given you, now in this original question you don't have any except option, and in that case my best bet would be plateau HCG, because plateau HCG favors invasive mole more than choriocarcinoma. Rajoshi, ETT is not chemosensitive. PSTT and ETT both are chemoresistant, and in both the cases you have to go for hysterectomy. Abhijit Kanojia, I think I've answered your question now. I am saying that yes, plateau HCG can be seen in choriocarcinoma, but more common is increasing HCG in choriocarcinoma than plateau HCG. Clear to all of you? Yes, ETT is chemo-resistant, PSTT is chemo-resistant. Invasive mole is chemo-sensitive, right? But just in case patient goes into shock, then I will have to do hysterectomy. Any other query you have? Okay, so I'm going to end this session over here only. And we will take up APH, PPH and management of third stage of labor sometimes in the coming week only, and I'll inform you about that session. I hope all of you have benefited from this session and you want me to continue taking these sessions, and yes, I will be a little more into practice of taking these kinds of live sessions where I am seeing your answers and telling you, teaching you simultaneously, right? Okay. Take care, bachon. All the best. Keep studying and keep following the weekly planner. Right?